Good afternoon, everyone. I'm Kimberly Chalia with PHCA. Thank you so much for joining us for today's webinar. A few quick updates to share before we get started. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for 1 continuing education credit for all attendees. For those who provided an ad number, credits will be uploaded shortly, and we'll also share certificates with those in attendance. As we begin today, all attendees will be in listen-only mode. Please feel free to submit your questions via the Q&A icon on the bottom of your screen, and we'll make sure to answer as many of those questions as possible at the end of today's presentation. Now I'll turn it over to Cheryl.
Thank you so much, Kim, and I really appreciate that wonderful introduction. And hello, everyone, and thanks so much for joining me. My name is Cheryl Scalzo, and I'm actually a clinical account specialist with real-time medical conditions. And sorry about that. I wanted to get my, there we go. Now I think we're up and running. Real-time medical is a technology where we have components where I love to share with you a lot about infection prevention and control. It's something that I did for a very long time in long-term care. I too am here with you all in Pennsylvania and served not only as an assistant director of nursing and what we used to call ourselves as infection control nurses, but also as a director of nursing for many, many years prior to leaving the facilities themselves and joining technology. And so today we're going to talk about that and what that looks like as we improve and strengthen our infection prevention and control practices, programs, and that's going to include our antibiotic stewardship as well. Remember here too that as we work through our presentation today, I want everybody to think about, and certainly obviously I'm going to be talking about some of those phase 3 requirements, and we can't help but talk about it because that's where our antibiotic stewardship came from, and that's where our defined infection preventionists has come from as well. But think about what are your current processes and identify for yourselves those areas that may need some improvement. I also hope to share today's strategies to not only improve your antibiotic usage, but also operationalizing through the requirements and policies in an effort to strengthen your programs as well as reduce antibiotic resistance and unnecessary adverse drug events. We'll talk a little bit today about risks and even think about too that risk of hospitalizations with our HAIs. Reminder here, that's being captured now as part of our QRPs. And then, of course, my favorite part is how live data analysis can strengthen our infection prevention and control resources and programs. So with our first slide, I always like to talk a little bit about what's new in infection control, but unbelievably, we are here in December. So I kind of grabbed onto a little bit of 2022 in review as it relates to infection control. We've also keep in mind here too, we've had some updates with our entrance conference form. So make sure you're always using your current entrance conference form, and we'll talk about that a little bit. But remember now that your phase 3 requirements, and they started for us back in 2017, 18, and 19, and we'll look at some of the regulations and need for new policies and procedures that came from that. But CMS has reminded us multiple times this year, and as most recently as just, within October, letting us know that they will and continue to enforce the view of those phase 3 requirements. And we know that we had so much of those related to our antibiotic stewardship and our infection prevention and control practices, not to mention, we're going to talk about some of those new regulations and some of that new guidance that came from our COVID-19 pandemic. We'll highlight what does our enhanced barrier precautions mean. That is one of our newer items. I think that came to us late summer. So we'll highlight that a little bit for us. 888 is that newest regulatory guidance related to infection control. Also keep in mind your state operations manual was updated just this past, I believe, end of October, middle of October. So you want to make sure that you're grabbing onto that. your revision history for your long-term care process. I always include this link because this is going to capture for you where you're going to be able to look at your survey resources and make sure you do have the most current entrance conference form. Do you have the most current critical element pathways? And we'll talk about that. We also have newer guidance that came out this year regarding the testing and management considerations for our residents with acute respiratory illness. And basically when we think about that one, remember here that if you have any residents, as we are deep in our influenza season, and I know that we're all aware of it, remember here that any resident with symptoms of COVID-19 or influenza, we must be swabbing and testing for both of their viruses. That's also going to help determine some of our placement decisions, and then what is your clinical management going to be with those. And then lastly, our mask mandate updates. I'll tell you, I've had lots of questions about this, and I even too have a lot of my own feelings about it. You know, CDC has changed our guidance for our mask mandates, and they've updated to note that vaccination status is also not going to be a part of that. There's also guidance as to how we're reporting our vaccines, but you know, when we think about the mask mandates, I want you to consider what's going to be best for your facility and for your resident population. Just because the CDC has lifted that mask mandate, and again, when we think about how we are in the middle of yet a lot of COVID-19, we're seeing again, and now we're seeing a lot of influenza. Is that necessarily the right thing for us to do? So do what's right for your facility, follow the guidance, follow the regulatory requirements. Some of us have state guidance, so think about that as well. I think our newest in Pennsylvania guidance that came out was in October. So think about that state guidance as well. What do you have? Even in Pennsylvania too, remember we have our, our Act 52, our PSRS. So we even have our own extra things here in Pennsylvania as well. But, and make sure your policies and procedures are reflective of that guidance. So when we talk about our nursing home resident and we look at our population, you might want to say, Cheryl, this slide is really almost self-explanatory, but is it really, when we think about this, look at it now. The CDC has reported to us that between 1 and 3 million serious infections occur in nursing homes annually. And as we unravel the regulatory process and attempt to become untangled, we can't forget why we are all here and why these regulations are in place. It is about our residents. And honestly, they are truly our most vulnerable population. I think that is something that we have definitely, if we didn't know it before our COVID-19 pandemic, I think it's something that we definitely know now, and especially as we are deep within our influenza season as well. Understanding the chain of infection. I always share this every time I talk about infection prevention and control. And the reason being, it's a great visual that you might want to be able to go ahead and grab and share with any of your team members within the facility. It's wonderful in being able to help identify and explain that chain of infection. And as we walk through it, I want to be able to highlight a couple of different pieces for you. I mean, right off the bat, I'm always asked, where does the chain start and where does the chain end? Well, it can start anywhere. And then really the chain is only going to end when we go ahead and we break it, because, we want to make sure that we understand what are these components. So if we look at that susceptible host, well, that's a person who is potentially vulnerable to an infection. And guess what? That's our residents. We've already established that and determined that. And we all know that. We have our portal of entry. So that's a site through which a pathogen can enter the susceptible host and cause infections, such as their urinary catheters or their central lines. We have that mode of transportation, that method or that route that an organism transfers from a reservoir to a susceptible host. This can be directly by touch or aerosolized droplets, or indirectly by contact with contaminated surfaces or intermediate vectors. And I'm going to pause here for a moment, and I want you to think about, what are we doing with everything that we are taking into our resident rooms, such as maybe our vital sign equipment, our glucometers. What do we do with our mechanical lifts that we take in and out of every single room? Maybe we have a Vanderlift for a particular hallway or a unit, and I have maybe 8 residents on that unit or hallway that use that Vanderlift. How are we making sure that we are not spreading or potentially spreading any infections every time we take that lift in and out of every single resident room? So think about this for every item that goes in and out of multiple resident rooms. Think about your IV pumps, your IV poles. How are they being disinfected, and are we ensuring that that's happening for us? Look at your tube feeding poles and your tube feeding pumps. And by the way, when you have your residents that are on tube feedings, make sure as you're getting ready for survey that that's something that we're looking at those residents' privacy curtains, the walls, the ceiling, because tube feeding can sometimes go everywhere and we don't even realize that it has gone everywhere. And so lots to think about when you're looking at that mode of transportation. I'll remind you here too that with those medication pass competencies, and we have to do them on every single one of our nurses that are passing medications to our residents. What infection control practices are they following? And are they following our policies and procedures when they are preparing and delivering any type of medication to our residents? So think about that too, and include that as part of your chain of infection. Your infectious agents are going to be those pathogenic microbes such as bacteria, parasites, viruses, or fungi, and certainly we all know that one. Our reservoirs are going to be the hosts or habitats such as our humans, animals, environment where the infectious agents live and reproduce. And then we have that portal of exit. So it's the route that the infectious agents leave the reservoir and can be via the nose or the mouth, urinary tract, or in blood or other bodily fluids. So your challenge here is, and for all of our team members, that we want to go ahead and be able to break that chain. And so why antibiotic stewardship? Well, no doubt that widespread antibiotic use has saved millions of lives by treating deadly infectious diseases. And antibiotics are among the most frequently prescribed medications in nursing homes on any given day. An astounding statistic here is that between 6 and 10% of nursing home residents are receiving antibiotics, and as many as 70% of residents will receive one or more course over the span of 1 year. Still today, the most common indication for our antibiotic usage in our nursing home remains, you guessed it, our urinary tract infections and our respiratory infections. So where do we begin here when we look at our infection prevention and control practices and our antibiotic stewardship? Well, obviously we're going to talk about our regulatory requirements, and then we know that with everything in long-term care, we have to take those regulatory requirements and we have to then develop our policies and procedures based on that regulatory guidance. Then this specifically when we talk about infection prevention and control, what systems do we have in place for our surveillance? And we'll identify, or hopefully I'll be able to identify for each of us, how important and significant that is to the success of our programs. Then also, what is your data analysis telling you? And then are we able to, based on all of that information that we have, be able to go ahead and put in provisions for improvement? So when we look at our regulations, gosh, I will tell you that many, many years ago, and it wasn't 880 because all of our tag regulation guidance numbers changed. We used to have one for infection control, one area of guidance. It was pretty comprehensive, but we had one area of guidance. Now look at us. We go all the way from 880 to 888, 888 being that newest one, by the way, that came out this year, and that's the COVID-19 immunization for your facility staff. I will remind you with that, and I think I'm coming up to it again. I think I have it as a separate slide, but just as a reminder with that, you do have a matrix as part of that 888 guidance. I'll cover it with you again, that we must be completed. So if that is something that's new for you and you've not been completing that matrix for your employees or your facility staff related to your COVID-19 immunization, make sure you're grabbing onto that. As we go through our regulatory requirements, just as also I'll share with you that infection control, by the way, continues to be among the top 5 cited deficiencies that our facilities are facing. So we have to kind of always keep that in mind. And With 880, which is our primary and most comprehensive portion of our infection control guidance, we have to be sure that we have that system for preventing, identifying, reporting, investigating, and controlling infections and communicable diseases. And that's going to cover all of our residents, our staff, our volunteers, visitors, and other individuals providing services under a contractual arrangement. So think about how comprehensive that absolutely is when we look at this initial policy. We also then have to have that system for recording incidents identified under the Infection Prevention and Control Program and corrective actions taken by the facility, and an antibiotic stewardship program. And that's going to then lead us to that 881. As the infection preventionist, I will remind everybody and recommend to you that you should have all of these infection prevention and control regulations. So 880 all the way through 888, and have your own separate binder with each of these regulations. Keep it in your office. Make sure you have tags or highlights or whatever you want to be able to do to quickly reference any individual area. But absolutely, as an infection preventionist, you want to be certain you have each of these regs right at your fingertips and available to you. So 881 now, we're going to be looking at that antibiotic stewardship program, and that's going to include our antibiotic usage protocols and a system to monitor antibiotic use. And the intent of this regulation is going to be to ensure that the facility develops and implements the protocols. And remember, what is antibiotic stewardship? Well, it's going to refer to that set of commitments and actions that are designed to optimize the treatment of infections while reducing the adverse events associated with antibiotic use. And we know that this is going to be accomplished through improving our antibiotic prescribing, administration, and management practices, thus reducing inappropriate use to ensure that residents receive the right antibiotic for the right indication, dose, and duration. We also have 882, and this is now where our infection preventionist has been defined. And don't forget that, this was initially reminding you part of those phase 3 requirements and really was supposed to be implemented by November of 2017. But we know that because of a lot of facilities, just didn't have that guidance under their surveys completed for the phase 3 requirements. And then it was all paused during our COVID pandemic. So some of us have not had that looked at, or maybe they're starting to have it looked at now. But your infection preventionist has to dedicate at least, that part-time or 20 hours a week just to infection prevention and control, and he or she must be certified. Now, that doesn't have to be SHE or APIC certification, which there's nothing wrong with any of those. You can actually go to the CDC's training site to be able to get that certification. And I'm going to tell you that I actually recommend it. If your infection preventionist is maybe new to long-term care, please go ahead and go through those modules related to or on the CDC training site. And you're going to find that at www.train.org/CDC train, and it will guide you then to those training modules that are available. It really pulls in all of those components of your infection prevention and control programs as it relates to long-term care. So again, if you're not familiar with it, please grab onto it because it really is a great certification program. So then we talk about 888, and I mentioned this a little bit before, it's that newest regulatory requirement that we have. I'm not going to dive into it too deeply. One of the things that we need to be sure is as each of these regulations come in or they change or they adapt, make sure, that we're looking at our policies and procedures. But here again, with this, I'll remind you all, you want to make sure that you have that matrix for your facility staff vaccinations. And I have included the link for that right on the bottom of this slide. So you'll be able to go ahead and grab onto that matrix and make sure that you have that up to date for yourself. So enhanced barrier precautions. It's kind of one of those newest recommendations that we have, and it's indicated for our residents who have a known infection or a known colonization with a multi-drug resistant organisms, when contact precautions do not otherwise apply. So contact precautions should still be used for the presence of acute diarrhea, draining wounds, or other sites of secretions or excretions that are unable to be covered or contained and may be used for a limited time period during the investigation of a suspected or confirmed MDRO outbreak or in consultation with public health. Additionally, remember here that enhanced barrier precautions are indicated for any nursing home residents who have wounds or indwelling medical devices, as these are residents that have that increased risk of becoming colonized with an MDRO. And while prior guidance focused on MDO outbreaks, novel and targeted MDROs in limited areas of nursing homes that were experiencing an outbreak, your enhanced barrier precautions is no longer limited just to those outbreaks. We now have that specific criteria. So really think about this now when we talk about your enhanced barrier precautions. I think that, when we first started talking about this over the summer, it really opened up a can of worms. And I had some different folks come to me and say, where do we even start with this? And, my answer was, and so maybe this is helpful to any of you, that if you've not yet addressed your enhanced barrier precautions, or maybe it's new for you and you've not yet developed your policies and procedures, get your general policies and procedures out. But as you start training the facility staff, you also need to make sure that you are training your residents and their family members, because you are now going to have your enhanced barrier precautions signs up. You're going to have those supplies, your PPEs at the ready. And so right off the bat, we don't want any of our residents or our families to panic that they have a super infection that now they have to be on precautions. We need to explain what enhanced barrier precautions mean, why we have this guidance, and what our policies and procedures are reflecting. So a lot of open and honest communication here as we talk about this. But what's significant, and I think what really comes into play, is we're going to wear our gowns and our gloves for our residents in high contact care activities that have those, those catheters, those indwelling catheters, those vascular devices that have those trach tubes, those feeding tubes. We have those open wounds where we're doing any of those dressings on, and even those residents that have those multi-drug resistant organisms, and we're doing those resident care activities such as our dressing, our bathing, our showering, our transfers, our linen changes, regular routine hygiene, resident brief changes, and so on and so forth. We want to make sure that we're keeping those enhanced barrier precautions. So lots of things at play here when we talk about those ABPs. And I know that, it's been a challenge for some of us to kind of get those up and running. And you know what, take it one step at a time. Take one each area at a time. Maybe you start this with your residents that have catheters. Maybe you're starting it with your residents that have those colonized multi-drug resistant organisms, and work closely with your facility teams, your residents, and their family members. And then just one last thing, I think this is a great tool for all of you, just to be able to share, again, with your teams, what guidance do we have? What PPE should we be using? Obviously, we know we want to make sure that we have the proper hand hygiene. What are we looking at when we're talking about our environmental cleaning and disinfection? How are we using those enhanced barrier precautions? What are you doing about auditing? And then communication, I think I've spoken about that quite a bit. In entrance conference form, I can't stress this enough. This gets updated, lately, a couple times a year. So you want to make sure that you're jumping into those links where we have our survey tools that are available to us, and make sure that we're keeping up with our entrance conference form and keeping that updated so that we have our survey binder ready. I do have a pop out here that's just reflecting for you that there are so many components of our entrance conference worksheet that are related specifically to infection control. Some of those areas are going to be required within 1 hour of entrance, and some of them are going to be required within 4 hours of our survey team entrance. So really, really, please keep in mind, that you have a lot of components on that entrance conference form related to infection prevention and control, and we want to make sure that we have that updated. And this is our critical element pathway. When I share this sometimes, with just a live audience, which I wish we were all today, I will often ask, who can tell me what this is? And not everybody knows about our critical element pathways. So I share it always because I'm a super, super fan of them. And really, it couldn't be more poignant because this is the one thing that CMS gives us. And it's actually that guidance or that look, that crystal ball kind of as to what are our surveyors looking at when we talk about those citations and our regulatory processes that we have within the facility. So we have critical element pathways for multiple areas within our long-term care world, and we want to make sure that we're grabbing onto them. Your infection prevention, control, and immunizations has just been updated yet again this fall, so you want to make sure that you have that most current one and go through this. Again, it really puts into perspective kind of what are some of those regulations meaning? What are they telling us? What should we be looking out for? Make sure that your policies and procedures can adapt to what some of this guidance to the surveyors looks like, and then grab on to the verbiage for each and every one of these areas to have within those policies and procedures. And I'm going to share with you, don't hesitate to share this with your team members. A lot of times, especially when we're going through survey and we talk about infection prevention and control, we could tell everybody till the cows come home, make sure our oxygen tubings aren't on the floor. And if we find any oxygen tubings on the floor or contaminated, in contaminated areas, that we dispose of them, we get rid of them, and we give the resident a new oxygen tubing. And we could say that over and over again, but if we don't explain why, even though I know it should seem simple enough that we should understand, let's make sure we're explaining why and even pull some of this right from your critical element pathways. I will also let you know, when you talk about your critical element pathways, get a hold of these, access them, download them. I've given you the links. I'll show you where, I've already shown you where the one link is in the beginning. I have links again for you at the end. I'm going to remind everybody to grab onto your environmental services, your pressure ulcers, that medication pass, dining services, and in a minimum, your kitchen, because those are all going to reflect and address infection prevention and control practices as well. So our policies and our procedures, and again, you might say, well, Cheryl, this is pretty basic. We kind of get it, but here's the thing with policies and procedures. Again, we want to make sure that we're looking at those regulatory requirements. And don't worry, I promise I'm not going to spend tons of time on this. But I think the thing here too is look at those revisions that we've had and be certain that we've updated our policies and procedures to reflect any of those new guidance revisions or new recommendations, such as our enhanced barrier precautions that have come out to us. And then also the significance here is, are we training our facility staff on any updates to our policies and procedures? Teaching our new staff also the information that they need to work or provide care differently for our residents based on our policies and procedures. And then here too, with your infection prevention and control policies and procedures, remember, they cannot be just in a binder up in maybe the DON office or the infection preventionist office. Part of your regulatory requirement is that your infection prevention and control policies and procedures are in separate binders on the units and in the departments and available to the staff at all times. So if your survey team comes into the building and they maybe go to one of the unit nurses or even one of the CNAs and say, can you tell me where you keep your infection prevention and control policies and procedures? They should be able to show you that. That's going to include your antibiotic stewardship policies and procedures as well. And if you look at your guidance to your antibiotic stewardship, remember that a lot of that is going to include listing of those most current drug classes of antibiotics that you're using, most frequent and common side effects, or resources as to where your team can have all of that information right at their fingertips. So just, we can really get ourselves into a lot of trouble with our infection prevention and control policies and procedures just with the guidance to those alone. And so here, when we talk about the infection preventionists and antibiotic stewardship, we'll dive into this a little bit more. And when we think about the infection preventionist, I mean, he or she is it, right? Like, you are the it girl or the it guy, and really the sheriff of all things infection prevention and control when we talk about that. And it's such a significant role. We know that he or she is assigned by the director of nursing and or the administrator, must be able to meet those minimum time requirements and be certified. And this has to be the person that can really work right alongside our team members, be able to communicate what's going on in the facility, educate our teams, our residents, and our families, everything that we possibly can as it relates to infection prevention and control, along with that surveillance of our signs and symptoms of our infections, that surveillance for our known infections, that surveillance for our antibiotic usage. There is so much going on with this person with this role. So we really want to make sure that, and I know that this is a hard thing to say because sometimes we have so many challenges related to staffing in the facilities, but let's make sure that we have the right person here that really will embrace this and be passionate about it and bring forward so much of the positive and encouraging attitude toward preventing that spread of infection for our residents and our team members. We look at the diagnosis of infectious disease, and I do bring this in here because not only does our infection preventionist need to be familiar with what we have when we're talking about our diagnoses, but we want to be sure that we've shared some of this information with our teams as well. Today, we have an expanding array of diagnostic tests that are available to identify those pathogens that cause our infections. Traditionally, we think about sending body site samples such as urine or sputum for culture, but we know that that takes time to grow in order for that true identification of our organisms. It also allows, though, that pathogen testing for susceptibility to different antimicrobials. So we know that that's so significant, but we do have our newer tests, such as our nucleic acid amplification tests that identify bacteria or their viruses based on their genetic material. We also have our polymerase chain reaction, or those PCR testing that might be right available to us for those quick and easy results, that often we're looking for. So a lot of opportunities here, but again, this is where our infection preventionists and even your team, your nursing supervisors, who's there on the weekends, who's there at nighttime, what do we have available to us? What do our policies and procedures reflect? Do we have guidance to our staff members as to what does our testing look like? What is our laboratory provider offering for us? And remember that our medical director and our laboratory provider has to be part of those antibiotic stewardship programs and part of your infection prevention and control programs as well. Remember, in Pennsylvania, we have to have those folks as part of our infection programs. Your role of antimicrobials in treating your infection, well, again, might seem like it's pretty simple, but we know that our antimicrobials are going to include also those antifungals, those antivirals, and your antibiotics. We certainly all know what those antibiotics do, and they're treating those infections that are occurring in our nursing homes. And that's some of the key concept about the role of the antibiotics and other antimicrobials. We have to know them as the infection preventionist and what are those common classes of what we're giving to our residents so that we can kind of strategize around some of those adverse effects that are coming from some of these drugs, as well as that's going to tie into our antibiotic stewardship programs. And I like this too, because I like to just highlight quickly, and again, I know it's knowledge that every single one of us have, but share with your teams, why do we have antibiotic resistance? Why do we have our multi-drug resistant organisms? Remind them that, this isn't new. I mean, this dates back to 1994. I think it was Newsweek, back in 1994 that had antibiotics on the front cover and, a skull. And sharing with us our antibiotics poisonous, because that's when we started really identifying those multi-drug resistant organisms. We didn't really start teaching about them until maybe late 1999, early 2000s, before we really started understanding and sharing with each other what it meant and how could we or should we start doing things differently. But remind everybody, how they came into play, how the misuse or overuse of antibiotics has played a part in the development of our multi-drug resistant organisms, and then also be able to explain, what do antibiotics do? How are they disrupting the normal flora of our intestinal tract? How do we have some of those superbugs, such as C. difficile, developing? And even when we think about our C. diff, among nursing home residents with C. diff infections, 75% of those residents, that's an outstanding statistic, have been exposed to antibiotic usage. So, it's right there, like kind of the proof is in the pudding, so to speak, there when we talk about, how does that antibiotic resistance develop? And I think that by explaining this to our staff members and our team members and even our families and residents, it kind of helps us, to be able to empower them to embrace our policies and procedures that are reflective of our guidelines. We have our 7 core elements of antibiotic stewardship. If you are not familiar with this, I have provided the link for you at the end. The CDC gives us a really great guidance to our antibiotic stewardship, 7 core elements. I will tell you that I still, to this day, keep my copy of it accessible. It is something that I go through on a regular basis. I make sure there's not been any updates to it because it just breaks it down, and, there's great simplification and guidance there. If we look at our first element of our leadership commitment, hands down, it is a team effort. That leadership is not going to just be our infection preventionist, but here, and you'll hear me duplicate some of my verbiage, that has to be our administrators, our director of nursing, our medical directors, our consultant pharmacists, our labs. Who is part of that leadership when we talk about our antibiotic stewardship? Yes, our infection control preventionist and our director of nursing are going to lead that and pull our medical director into that, but it's going to take a village here. It's not going to just take that one person. And then we do need to have that backing and that support as we work through our core elements. Who's accountable? Honestly, it's going to be everybody. When we talk about our physicians have to be, it's not just the medical director here. We're going to be talking about all of our physicians, all of our advanced practice clinicians. Do you have nurse practitioners ordering antibiotics? Do you have physician's assistants ordering antibiotics in the facility? If so, they are going to need to be educated as well. You have your entire nursing team, your pharmacy, including your consultant pharmacist, has to and must be a person who is part of your antibiotic stewardship. Your drug expertise, well, guess who I'm going to talk about here again, right? That consultant pharmacist. They, it's part of the regulations that they're part of our antibiotic stewardship program, but there's a reason being, this person is going to have that expertise for us. They're going to be able to be the ones that are going to catch for us when we have those, extraordinary potential adverse effects that are occurring with our residents. They can also assist us doing some of that antibiotic stewardship training, especially with our physicians. So I always like to point that out. Sometimes that's where we struggle, and sometimes we even struggle getting our own medical directors on board when we talk about some of these policies and procedures and programs that we need. So, pull that consultant pharmacist in there to help us out as well. And then when we talk about that action, this is where we're going to be implementing our prescribing policies, making sure, again, that our nurses understand, what they have to think about, what we're looking at, and then how to strategize and evaluate and manage our infections. With our tracking, and we'll talk about this a little bit more in a few moments of some more detail of our tracking. What do your current tracking processes look like? How are you measuring your antibiotic usage? How are you monitoring your outcome measures? And are you able to, and have you, and then what have you done when you identify any breaches in your stewardship program? Also with reporting, here you have to have a provision of feedback. Remember, infection prevention and control has to be part of your QAPI processes, and that can include your antibiotic stewardship as well. So do you and have you allowed that provision of feedback? Are you having these conversations? Who's part of your separate antibiotic stewardship program and committee? Are you improving any practices? And then are you able to identify how you're improving some of those resident outcomes? And then the education, I mean, this is, kind of goes without saying, but, maybe it doesn't. We have to be certain that everybody is understanding what is our facility antibiotic stewardship program. And we really have to work at kind of breaking those old beliefs, because this is where we really want everyone to go ahead and embrace how we can go ahead and improve what we're doing for our residents here. So some of the key strategies that we have when we talk about our antibiotic stewardship programs, we have like 4 different particular areas that the CDC has defined for us. And the first one is that we're absolutely measuring our antibiotic prescribing. So they're telling us that we have one of 3 ways that we can measure that antibiotic prescribing. And that's either going to be through your antibiotic starts, your antibiotic days of therapy, or also your point prevalence. You have to have at least one metric as to how you are measuring that antibiotic usage. And then as a reminder with that metric, you have to be looking at your benchmarks and reevaluating and setting a new benchmark for yourself at a minimum annually. I recommend that you actually try to look at it and do it quarterly if you can. But with those metrics, you want to make sure that you're setting an area of improvement for yourself. But I will remind you, you do not have to have areas of improvement by leaps and bounds. If you maybe are only doing it once a year, look at it quarterly, consider maybe semi-annually in 6 months. If we've done really, really well, maybe my point prevalence metric, last year was 36%. We reset our new benchmark at 30%, but I see that we're actually now down to 23. Well, go ahead. Maybe in 6 months, then you want to go ahead and reestablish that. Remember, if you find that you have any breaches or you're not doing as well as those benchmarks, that's where we want to go ahead and put those provisions improvement in place. And anytime you do that, you want to work it almost as though you're providing a plan of correction for yourself, kind of doing that internal plan of correction. We talk about those key strategies. So here's where we really want to establish that communication with our residents, our families, our physicians, with our healthcare providers. And the IP is really going to be that person who's going to help do this. I think about how to improve those prescribing practices. And every single one of us on the call, I can guarantee, have been faced with where, we have a resident on a Friday evening that maybe has some mild symptoms of a urinary tract infection. And, so I've met the criteria, we call the doctor, and really all we're asking for now is to get an order for UACNS. Well, it's a covering physician, and he says, go ahead and get the UACNS. And then after you do, go ahead and order that Cipro 250 BID, but then, call the primary when the culture and sensitivity come back. So lo and behold, now we're faced with maybe on Sunday evening, that culture and sensitivity comes back. And guess what? Either the resident has less than 10,000 organisms, the resident has less than 100,000 organisms and doesn't have enough symptoms, or, maybe the organism is not sensitive to that Cipro that we've ordered. So here now we're looking at where we have misused that antibiotic. And this is part of where we have those breaches within our antibiotic stewardship programs. So just like everything else, when you find that breach, now we want to go ahead and re-educate that nurse that took that order, and we want to re-educate that physician, even if it was that covering physician. And don't forget, use your pharmacist and your medical director here. The 5 Ds. So this is where the CDC is letting us know that we want to be sure that with those antibiotic orders, we have the right diagnosis, the right drug, the right dose, the right duration, and is there a need for any de-escalation of that antibiotic? So let's make sure then that we have all of our 5 Ds in place, and that should be part of, not only should every one of our nurses that are taking orders be aware of that, but the IP should be looking at that as well. And then ensure that we have prompt initiation of the right antibiotics when they are needed. This is part of your surveillance and your tracking and your trending. What we don't want to see here, and what we often do, is that maybe on an off shift, an antibiotic didn't get started, and maybe the nurse is documenting not given due to unavailable from pharmacy. That cannot be. Your antibiotics have to be treated as one of those high-risk medications that are being looked at by our surveyors. We have to have those antibiotics available, have a process in place that if our pharmacy cannot deliver it to us timely, do we have an additional local pharmacy that can get it to us timely if it's something that we don't have in our emergency box. So let's make sure we have our provisions in place ahead of time. What we don't want to see is that we're not giving our antibiotics as prescribed. Okay, so surveillance, well, what is it? Well, and you're probably all going to say, well, Cheryl, we kind of know what it is, but there's so many things that can come into play when we talk about our surveillance. And I think that the trick here is, and I'll let you kind of review the slide, I'm not going to read it to you verbatim, but I think the trick to our surveillance is capturing that data that's locked within your electronic health records, and then also identifying for yourselves those performance improvement opportunities. The trick here too is, do our staff, our nurses, our CNAs know what to look for? And then do they know how to document and how to give us what we're looking for to help with our surveillance and our collection and analysis and interpretation of that data that we're finding? Our surveillance is only going to be as good as the documentation that is entered into our electronic medical records for our residents. So this has to be part of that education that we're giving our team members as well. And then we talk about technology and what is that doing for us? Well, think about the time-saving capabilities. I'm going to tell you as an old timer, and yes, I am, because I've been doing this for, oh gosh, like well over 30 years now. So, but when we think about, that what I used to have is multiple binders that I would have literally laid out on the floor, in the space that I had to call my office. My desk would never be big enough. So I'd have binder after binder, where I'd have things laid out to be able to show all of that surveillance and tracking and trending that I've been doing in looking at my infection, information. But now what our technology can do is it's easily letting us and consistently develop that complete data process, letting us establish those benchmarks. And instead of having those multiple binders opened, we have all of that at our fingertips, which is giving us now more time to be able to put into place or implement those corrective interventions and provide that competency-based training and education where it's most necessary. So this first area that we're going to look at now is that antibiotic surveillance. And remember, I reminded you all that you have to have at least one metric as to how you are measuring your antibiotic usage. So quickly here, what technology is going to help us do is look at identify those new antibiotic orders, look at those 5 Ds, make sure we're tracking and trending our metrics, reestablishing those benchmarks. And I will remind everybody, as you're identifying those active antibiotics that you have happening in your facility, look for any lingering PRNs that we're no longer using. Look for those nystans. It's an antifungal that you've been using for the last 780 days. Your Department of Health surveyors catch that, guess what? They're going to ask that resident, do the nurses put your nystatin cream underneath your abdominal folds every night as ordered? And what's going to happen, possibly because it's an older order like that, we might have a resident where they say, oh yeah, the CNAs put it on me every night, or no, nobody's put cream on me in a long time. So, that those can get us into trouble. Or the surveyor is going to say, I want to see the skin assessments related to this nystatin, because we don't want to get caught with any unnecessary medications. And believe me, it can happen. It has happened to me. So just kind of keep in mind, what do you have out there outstanding? Is any active antimicrobials for any of your residents? We look at our infection type, and I just love this analysis because it's able to let us see now what is going on in our facility. I can look at what do my infection types look like? Where do I need to spend some of my focus now? It's also going to help us with our mapping or our locating. That is part of our regulatory process for our infection prevention and control. And remember here too, in Pennsylvania, we have Act 52, so we have PSRS on top of it. You know, we're identifying those infections, we're identifying those antibiotics. Some of them are going to meet those criteria of our definition that we have to make sure that we're reporting. But also here you have your mapping and your locating portion as part of your IPC program. And we have to make sure that we're grabbing all of that information. Also here too, look for your trends. If you find a particular area in the facility that is trending higher with a particular infection type, get your hands dirty and start doing that competency-based training in those interventions. We also have your antibiotic orders by class. Know your drug classes. This is the information you need to make sure that your consultant pharmacist has access to. Also, hopefully your lab is helping you with those antibiograms. But think about this too. You want to know as an example, because there are so many adverse effects that can happen with our antibiotics or our antimicrobials. But remember here too, we have to know who are those residents that are receiving cephalosporin therapy, because are they also on Coumadin or warfarin? And if they are, let's make sure we get some additional INRs in place. There's other drug classes with our Coumadins and warfarins as well. Know who your residents are that are on those quinolones or fluoroquinolones. Those are the ones that are going to be at the highest prevalence for development of a C. difficile infection. Share that listing with your dietitian. Maybe get some extra yogurts in place. Or do we need to reach out to the doctor and maybe get some lactobacillus for these residents? Know who your residents are that have a healthcare associated infection versus a community acquired infection. So our healthcare acquired infections or our nosocomial infections, not only do we need to do that tracking and trending because we absolutely need to know if we have the spread of infection anywhere throughout the facility and do we potentially have an outbreak, but also here remember that our residents with a healthcare acquired infection that are now going out to the hospital because of that healthcare acquired infection are part of our quality reporting program under our quality measures. Our consumers, our customers, our potential customers can see that on Nursing Home Compare. So it is part of that reporting requirement. And then also here too, we have our prescribing practices. And I like to always share this one because I want to remind everybody, at a minimum, once a quarter, you have to be sharing with all of your physicians and your advanced practice clinicians their prescribing practices when it comes to your antimicrobials, your antibiotics, your antifungals, your antimalarials, etc. You have to be sending that out to them. Who's looking at their prescribing practices? Who's providing additional education when they're breaching your policies and procedures? This is something, and really AHRQ helps us with this, has kind of a really nice layout and format for it. But make sure at a minimum once a quarter you are sharing those prescribing practices with your physicians and your advanced practice clinicians. The last thing I like to highlight when we talk about our infections is just that little bit of risk. Our infections, when they're occurring with our residents, are really placing them at so many other risk areas or heightening those additional risk areas. We know that often our residents now are going to be at higher risk for falls, potentially even falls with injury. They're going to be at higher risk for development of pressure ulcers. Do they now suddenly need incontinency management where maybe they didn't need that before? Do they potentially need increased assistance with their ADLs, their mobility? Are they having any pain? What are their weights and hydration going to look like within, what's going on with these infections? And remember here too, with our elderly population, sometimes they actually, the first telling sign for us that they have an infectious process happening is that they have a decline in their appetites and a decline in their fluid intake. So before they even have any outward symptoms of an infection, we need to be looking for those infection processes based on their appetites and their hydration status. So once we've identified that infection, they may already be days into having those poor appetites and fluid intakes. So kind of think about that when we talk about our risk management process, with our residents, and really kind of consider, adding some additional pieces for these residents. Next, I want to be able to share very quickly how technology can look at some of that risk mitigation. And these are just examples. Please remember that these are absolutely not all inclusive. But when we think about our pressure ulcers, do the residents suddenly have an increased need with their ADLs? Do they have an increased, or do they have a decline in their appetites? Are they having new incontinence? And we can kind of go through every one of our risk areas and mitigate that risk when we talk about, looking at this. And then even through that infectious process, when we have our residents with our infections, do we need to now look at getting them on that documented repositioning? How are we assisting them with their bed mobility? Do we have a draw sheet in place if that's something that's part of our policies and procedures? Do we now need to update that plan of care to assist them with feeding? Also, even let's think about that bowel and bladder management. So a lot of opportunities here when we think about that risk. And then just a little bit of a recapitulation and, some of our key points. I think, that early identification, I probably didn't hone in on it enough, but it is so, so significant when we talk about our infection prevention and control practices. And then I'll let you be able to go ahead and view, some of those other key points. But I also want to be able to highlight for you, don't forget that any of your residents that are coming into the facility on admission with an infection, you want to be certain that you are including that infection and any needs that they have on that baseline care plan. Remember, your baseline care plan must be done within 48 hours of admission, and your infections are going to fall under that as well. I've also saved for you a lot of resources, so multiple resources available for your enhanced barrier precautions. So if that's something that you've not been able to grab onto, I wanted to be certain that I shared that with you. Here's some additional helpful resources and links. A lot of opportunities with your core elements of your antibiotic stewardship and some of that oversight with your infection prevention and control guidance. Don't forget, we have a new update this past October in our state operations manual. And then just some additional guidance through the CDC as well, in case that's not anything that you're familiar with. I will also now come back to, and I think I'm going to be able to go ahead and stop sharing my screen. I'm not sure. I want to be able to see. I think, Kim, was there a question that came in?
There was. I actually just answered it. They were interested in obtaining these slides for today's session, and I will be sharing the slides with the certificates that go out with the session today.
Perfect. Thank you. I'm happy to answer any other questions if anybody has any other questions. If not, I will say thank you so very, very much for your time and for spending this last hour with me. I really enjoy it, and happy to be able to share this information with you, and wish everyone lots of luck as we continue to work through all of the challenges that we face in our long-term care facilities. And also, even though it's a little bit early, but it'll be here before we know it, happy holidays and happy new year to everyone. And thanks, Kim, so much for having me.
You're welcome. It actually looks like we did receive an additional question.
Okay.
Are you able to open the Q&A channel?
Yes.
All right. Perfect.
Yep. So does every infection nurse need to be certified? So the answer to that is that every infection preventionist defined for your facility, yes, must have some type of a certification. And so there's a lot of opportunities here, and that is actually part of those regulations. So if you go through the slides, you'll be able to see that I've actually pulled that right out for you. And that's going to be part of, I believe that's 881 off the top of my head is where our 882, where our infection preventionist is defined. So a free certification that you can do and that is acceptable is to go right to the CDC, and you're going to be able to go to it's CDC .train, I believe, .gov. Just enter the CDC training and you'll be able to grab onto that. I think I do have it for you in the handouts as well, but it's a great program. It is free. There are about 27 modules, or I think with including the antibiotic stewardship. So it takes a little bit of time to get through it, but it's a really great program. I will also let you know that the certification board, so CBIC or CIC, is also now offering free certification testing for those that are meeting the criteria, and it is not strict criteria. So anybody who is carrying that role of the infection preventionist in the facility, it's really minimal information that you provide to them, and you'll be able to go ahead and get scheduled for any of those certifications as well. So I hope that answered that question.
Yep, it looks like we have another one that came through.
Okay, should it be an RN? So you actually can have an LPN as long as that LPN is going to go ahead and meet the criteria, the minimum criteria of getting that certification, and then also being able to meet those minimum requirements. I think that sometimes too, our surveyors, really try to support us as long as we have that licensed nurse, in that role. They're able to support that being an LPN as well. And the LPNs can go through, typically the LPNs aren't going to be able to go through that CBIC or that CIC, that board certification, but absolutely can go through that CDC training.
Thanks, Cheryl. It looks like that's all of the questions for today. If anyone does have any additional questions, please feel free to email Cheryl or myself, and we will get right back to you. I appreciate everyone's time today.
Thanks so much, Kim, and have a great day, everyone.
Thanks. Bye.
Bye-bye.